Hello, I'm Norman Swan. Welcome to this programme on continence and men's health. It's the first in a new three-part series on continence. Most men will be more worried about their home plumbing than their own. They're also not inclined to talk to their doctor about the problems they're having with their waterworks. And it's those problems, if untreated, can seriously affect their work, sporting activities and sex life. Tonight we'll look at continence in men and the strategies for engagement with men about these issues, early intervention, assessment and management. As usual, there'll be a number of resources available for you at the Rural Health Education Foundation's website, and that's at rhef.com.au. Now let me introduce our panel to you. Prem Rashid is a urologist from Port Macquarie in New South Wales. Welcome, Prem. Trina Gregory is a general practitioner, also from Port Macquarie in New South Wales, who's looking after the shop tonight. Trina?
Someone, I hope.
Peter Dornan is a physiotherapist at the Toowong Rehabilitation Centre in Queensland. Welcome, Peter.
Thank you.
Steve Marburg is a continence nurse and coordinator of the National Continence Helpline with the Continence Foundation of Australia. Welcome, Steve.
Norman.
Virginia Ip is a continence and urology nurse and the urology care coordinator at Royal Prince Alfred Hospital in Sydney. Welcome, Virginia.
Thanks.
So welcome to you all. Steve, many myths about male incontinence?
Other than the fact that only women get it.
That's what I thought.
No, there's certainly a lot of myths about men and incontinence.
Women don't, it's only women, and you only get it after prostatic surgery and never any other time.
No, you never wet the bed when you're a young man or anything like that. Or you have any problems rushing to the toilet. You'd rather go behind a tree, maybe. But no, there's so many myths. But, you know, really it's just something we just need to talk about on the helpline and whatever else we can do.
So do you actually sit on the line, so to speak?
I certainly do, and talk to people Australia-wide about bladder and bowel problems. But as the male on the helpline, I get a lot of calls from certainly post-prostate and a number of younger men as well.
What's the most troubling call that you get, sort of call that you get?
Probably the post-prostate radical prostatectomy call, that someone who's come home and not really sure what to expect, and is very concerned about the fact that they've been told, look, you know, the problem will be there for a little while, but quite often the little while to a male is about 12 hours, but to a urologist or a doctor is 1 to 3 months.
And Peter, later on in the programme we're going to come to your experience, because you walk the talk, so to speak. You've been there.
Yes, it wasn't the plan, but I certainly have done it, and it's, I can share my experience with you if it will help.
And Trina, in general practice, you'd see pretty much the same sort of range as Steve gets on the line.
I think it's anybody's problem, any age, any sex. Obviously different ages, different sexes have different problems, but I think it's one of those things that we need to talk about.
So do the blokes ever come in by themselves, or are they dragged in kicking and screaming, or dribbling, should I say, by their partners?
No, they actually do. It's quite encouraging to see how many people will come in, men, and talk to a female doctor, or women and talk to a male doctor, and actually come in with problems.
What are the statistics, Virginia? I mean, what sort of proportion? You're going to flick that one to Steve, are you? Just
yeah, I think
flash
Steve
of
knows
worry
all the
in your
numbers.
eye.
And I thought, oh, well, he'll be a number man.
Well, we do have to know the stats on the helpline. Up to 4 million people are incontinent in Australia, and of that, 30% of them are male. So it's still a fair number.
Prem, how do you look at this when you categorise it in the typical symptomatology?
I guess basically we start off with the definition of urinary incontinence, and it's basically an involuntary loss of urine, and that's either due to bladder malfunction or sphincter malfunction. And we tend to categorise them up to 7 categories, but I've put about 4 there for us to look at. The common ones we know about: stress urinary incontinence, where you cough, leak, sneeze, laugh, leak.
So the same issue as women, but men get it too.
That's right, and that's more common with post-radical prostatectomy. We see that quite typically. Urge incontinence is where you get that urge and you can't suppress it and then you leak because of that. And that could be the feeling of a drop, or an actual drop, or much more than a drop, to wetting your pants. And then the common one is actually the mixed group, which is a mixture of stress and urge. And that's the majority of what we see. I think if you ask people quite carefully, you'll realise that even in women they would get the mixed picture. There'll be more of one than the other. And overflow incontinence is another one, where we get a situation where the bladder is just overfilled. And
due to an obstruction? Usually
due to an obstruction or failure of bladder contraction and then leakage.
Virginia, Well, we're talking about myths here. I mean, that's a very similar picture to women. There might be slightly different causes, but my understanding is the commonest cause is the same. It's an aging bladder and an aging neurological control system.
Yeah, that's right. Yeah, in men you do also get a lot of stress incontinence and urge incontinence and mixed incontinence like the woman.
How much stigma is there?
People are, this is incontinence. A lot of them have this dirty connotation. They think you're wetting the pants, you lose your independence, and you can't go out in public because you smell. And some people do not confess to the family they had a problem and they don't want to get help because they worry that the family might reject them, and also from friends, rejection from friends. So they actually stay at home because, if they had an accident in the past, they're very, very embarrassed to go out in the public. Let's say if they've wet themselves, that they're not prepared. So that affects quite a lot of people's quality of life because of the incontinence. And because it's such an embarrassing problem, they don't get help. And also another issue with incontinence, because it's not a life-threatening condition, a lot of people will just put up with it because they didn't know they can get help.
And with modern, presumably, while you're treating it, with modern devices, even pads, smell is not an issue. No,
but I think the message here is for people to go and get help. A lot of the, I would say, because I speak on the behalf of the continence nurses, we could recommend a very suitable product, or can get products for them to try, make sure it's suitable for them, and still enable them to have a normal activities, so they're not limited by the incontinence or by fear of smell or soiling in public.
And are non-Anglo men less or more likely to come forward? Are there different cultural issues here?
I think the stigma is the same in non-Anglo-Saxon men. I had a lot of experience in dealing with Chinese community. In Chinese men, it is same like Australian men. There is, they are the leader in the family. They provide for the family. They have that strong image, so they don't want to be seen as weak and dirty, being incontinent. So they don't like to go and seek help. From people with non-English speaking background, if their English is proficient enough, they might go and get help because they can look up for information or talk to health professional. But people with poor English skill, if they had to rely on an interpreter, let's say a family or a professional interpreter, it's really hard because you had to get your message across to another person. So this is not easy for them to do. In people with different culture, you also consider, especially the elderly people, they had little formal education. They might even illiterate in their own language. So if you give
so it
them,
doesn't even make a difference if you're going to do it in Mandarin or Cantonese.
No. So if you give them something to read, they can't read it. So I think for continence promotion, we had to take a different way rather than just giving out pamphlets.
Steve, what about Aboriginal and Torres Strait Islander men?
In what way? Just
in terms of the issues that you might have.
Well, I know that it's a shameful act. It's a shame job, I believe the language is, and it's so embarrassing to talk about it, and especially when you're talking about elders who have a lot of respect in the community. To be incontinent of any sort is very difficult, and I suspect it's somewhat harder to hide because the cost of products and things like that that would otherwise might be useful may be an issue too. But certainly the resources of getting help for that community is really important.
Trina, in general, as a general practitioner, how do you tend to engage men? What sort of tricks have you got history-wise to draw them out if there's an issue there, which could be hidden?
I think it often is hidden. Hopefully in general practice, one of the things that we do try and do quite well is to get a professional relationship with our patients so that they feel that they can trust us and diverge confidential and sometimes embarrassing information. But certainly I think we have to ask at times, slot it into the conversation. Certainly when we do our preventative health checks in our 75 years and older and our 45 to 49 health checks, and anything else you might be talking about, preventative health or just talking to the men about their health in general, I think it's really important to actually ask the questions and to ask it in a positive way. You know, maybe saying, you know, a lot of men do have problems, and if you do, you know, I can't really help you unless you tell me, but, you know, I'd really like to know.
Do you often
so
get surprises?
Yes, quite often. Certainly I think more so with women, certainly younger women, when we're doing pap smears and things, and they think it's normal to be wearing a pad and have continence issues, which of course it's not. But yes, I think there's always surprises in general practice, and I think what we mustn't do is not ask. I think, you know, whatever we do, we need to ask and then offer the help that we can.
So rather than just get into a technical discussion about management, let's do it through some case studies and see how it pans out in terms of evaluating, assessing people and coming to the right diagnosis and actually working out what the right management might be. So let's start off with Jason. He's actually 23 years old. He comes to see you, Trina. He's being dragged in by his girlfriend, who's actually his fiancée. He says he's actually never been dry at night. He wets the bed. He was told when he was about 12 by the GP he saw then that he'd grow out of it, but he hasn't. It's particularly bad when he's had a few drinks. And he goes quite a lot during the day and he's no idea what to do. Well, what's he to do?
Well, I think the first thing we need to do is compliment him for actually coming in and well, nice of his girlfriend to stick by him and actually want to help him. But I think, as with any case in general practice, we need to approach it in an ordered fashion. So really good history. Has it been all the time? Has it changed? Is there a pattern? What treatments has he tried? What investigations? Have there been treatments that have failed? Or
so he's never been dry at night. He can remember. And he can remember his parents trying all sorts of things, restricting fluids at night, which he still tries from time to time, but doesn't seem to do any good. He remembers trying the alarm and waking up, and that didn't do any good. He's even have the stuff that you sniff up your nose, but you know that works occasionally, but it's still not right.
So I think the first thing we need to do is really examine this guy quite carefully. General examination, check his blood pressure, do a urine dip, catalase test, sugar, examine his tummy, have a talk to him about things, and possibly then I would think about going on to do an ultrasound to have a look at his bladder volume and pre and post voiding.
What's that going to tell you?
Well, it's going to tell
23-year-old.
Well, it's probably quite significant what his residual volume is. If he's emptying properly, if he's got a bladder that he feels the urge to need to go with a small volume, if he's got a sensitive bladder, or if he's got an outflow obstruction or something like that. So I think that would give us some good information. The other thing that would be...
So you get a sense of whether he's got a small irritable bladder.
Yeah. Yeah, and I think the other thing, it would give us a sense of his general health as well, if he's got proteinuria, high blood pressure, some renal disease. And the other thing that would be quite useful would be to get him to do a bladder diary to actually see what is happening. And he could quite easily do that while we're waiting to get results back and while we're still investigating him.
So Virginia, what do you need to know when you do a bladder diary?
We normally ask people to do 3-day bladder diary if possible. Recording the time, the fluid intake. From the fluid intake, we actually can identify whether they are drinking a lot of caffeinated drink or drinks with like the soda water and Coca-Cola, alcohol. And the output we can identify how often they need to go, what is the minimum interval between the voids, the maximum interval, and the minimum amount and the maximum amount.
So they measure their urine volume?
Yeah, they actually measure to record it. And then write down the comment, when do they leak, and is it on the way to the toilet, or if they go for a walk, they have leakage. So the bladder diary is a very useful tool. When patients come in, we do this as the first line assessment. And you can also do it halfway. You can compare the progress, and you can tell the patient, look, from the first time you do this now,
so you
can see the improvement.
So Steve, I mean, nocturnal enuresis is actually not that rare in this age group, is it? It's just they just don't talk about it.
They just don't talk about it. It certainly happens. I mean, most young men that call me on the line, you know, are surprised that they think they're the only one that has it, and so I certainly reassure them that it's not unusual. It's not common, but it's not unusual to be still wetting at this time of at this age.
So, Prem, everything that Trina's done is negative. His fasting blood sugar is normal. He's not got any glycosuria. He's there's nothing in his wee, but when you do the bladder diary, he's probably going 12, 15 times a day, small volumes, and there's only 2 or 3 nights of the week that he's dry.
Yeah.
What would you be doing for him?
And we know he's emptying, so this is a small bladder.
Yeah.
So I guess that excludes all those other dangerous things that it could be. Then it's a difficult thing because he's a young guy. We're going to have to bladder train this guy and try and build up his bladder capacity. He's going to find it difficult because of the urgency. So as we try and bladder train him.
Before you go on,
yeah.
Low bladder capacity is not necessarily a correlate of nocturnal enuresis, is it?
No, no. There could be other things going on in terms of developmental issues that he may have had, because we know he's had this ever since he was a young boy. So we do need to, if we've done the ultrasound, we know he's not got upper tract dilatation. We know he's not got any renal dysfunctions, we excluded those. But what we haven't covered, I guess, are the neurological possibilities. We need to make sure we haven't missed a neurological problem in this boy from a young age. And I think examining him, as Trina suggested...
So like spinal
cord. Yeah, and that would probably be the thing that comes to mind. And if I think there's ongoing doubt and I think neurologically there's something not quite right with him, then he probably needs to see a neurologist.
But if he's got straight nocturnal enuresis, Steve, what would you be suggesting here? Just would you try an alarm again with him?
I think at 23, I think it's fairly unlikely it's going to succeed.
Well, mummy's not going to run.
No, it's going to wake him up if he doesn't wake up, especially if he's been on the alcohol the night before.
Girlfriend might, though.
Girlfriend might. But I can't see it working. I think it's going to come down to training and medication, possibly.
So, Virginia, describe how you take somebody through a bladder training program.
Well, I will explain to the patient. The bladder is like a balloon. If you have small amount of air in the balloon is going to be small size. The bladder, if you have a small amount in there, is always small size. The bladder training is the patient got to drink more fluid and hold on, like the deferral technique, so the bladder in time will be able to hold a bit more, and then they don't have to go as often. A lot of patients come in will tell us that they only drink small amount because they want to limit the fluid restriction, so they don't have to go toilet as often. We'll tell them, because you actually limited the fluids, your urine is very concentrated and actually irritate the bladder. You're still going to many times, but you're just doing the small amount.
So it's a bit like nocturnal enuresis, where you really encourage drinking. You don't get into that vicious cycle.
Yeah. With the bladder training, we also tell them some distraction technique. Like if they need to go, we encourage them to hold on maybe a couple minutes to start with, to increase the time they can hold on a little bit longer.
So keep going till your eyes water. No, maybe not.
Cross your legs,
cross your legs,
ring a friend.
Towel between the legs. Yeah.
Distract.
Just keep yourself going for as long as you possibly can. But increase it as you go, but do it in a planned way.
Something as simple as sitting down takes gravity out of the equation, so that may help you defer that little bit longer.
I'd also add that the stronger your pelvic floor muscles are, the more chance you've got of holding on for longer. So
pelvic floor training even in a 23-year-old?
Yes, too right. I mean, they can be, if they haven't done deliberately, if they're not a particularly fit person, the pelvic floor muscles may be weak, but they've got to be specifically trained anyway to do this job.
Okay, Peter, train us. Go on, we're ready. We're sitting here comfortably.
Would you like me to tell you how to do pelvic floor training?
Yeah. Go on.
All right, well, there's 3 muscle groups.
Come on, you've got to do it too, so please sit up straight now and just get ready. Okay. We're all going to do it together.
Sit back, uncurl your legs, and what I want to do is take you through the 3 basic exercises for basic pelvic floor training.
Okay.
And the first one, you
can I talk at the same time or not? No.
You can do it. Yeah, in fact, it's like any other muscle. It's like doing that for a biceps. You can talk while you're working your biceps. Once you can do your pelvic floor exercises, you can do them underwater, any party, anytime, if you wanted to do that. Right. There are 3 muscles, and the first one is, there are 3 exercises to do because the 3 muscles sort of relate to forward, middle, and back. The first one, I would suggest that you're at a party like here, and you're going to pass wind, and that would have to happen. So the first thing I'll get you to do is to close off your anal sphincter, the one at the back. Simply hold it for 5 seconds, and you can feel it coming on. You've done this before many times. 1, 2, 3, 4, 5.
How much do you know they're doing it? Are they just because of the smiles on their faces or what?
Well, they've either done it or they're not going to let us know. So that's the first exercise. It's not hard to do. The second one is the penile one in front. And that is, imagine you're going to pee on the floor.
Trina, you're let off this one.
And you don't want to do this. So you're going to hold, you're going to pretend you're going to cut across your stream. And that's not a hard one to do either. We do that regularly.
And how long do you hold for?
For 5 seconds again.
Okay.
The third one is what's called the perineal area between the scrotum and the anus. And you imagine you've got a red hot poker on the end of your finger, and you're going to put it up behind the scrotum onto that onto your perineal area. And you don't want to burn it, so you're going to drag it up into your pelvis, up in your cavity, up in your pelvic cavity. It's very similar to if you're going to drag your testicles up there, so it's not hard to sort of imagine.
Right.
So you hold that for
but you don't need to get a lump in your throat at the same time.
I don't think he's breathing. I think he's
I'm still thinking of the red hot finger here. I just start thinking
but he's allowed to talk,
mind,
it means. Now what happens now is that those 3 exercises, you don't really do them individually. No one does them individually. When you fire off one, the whole 3 recruit. So the idea is to do them all as
So that first exercise was really to become aware of where the...
To try and train, and indeed, later on, what we're going to suggest is that people learn how to do these before prostate surgery, for instance. And if they can do them, if they can get a pattern to the brain, so the brain knows what they're doing...
So how often do you do them?
You'd need to do them about twice a day is all you need to do them. 5 times fast and 5 times slow.
5 times 5 seconds?
5 times for 5 seconds is slow, because the pelvic floor muscles are about 2/3 slow twitch muscles and about 1/3 fast twitch.
And how fast is fast?
Fast is 1, 2, 3, 4, 5. As fast as all that, because you've got to train them to get out of chairs and to move things around the place.
Well, particularly if someone's coming out with a red hot poker, absolutely.
Indeed, and you would. and so you just simply, you get them to do 5 times fast, 5 times slow, about twice a day is really adequate. You can do it more if you like, and you're going to get a bit more endurance. And you can get a bit more speed into it. But at the beginning, if you do any more, you're going to get yourself exhausted. It's not that important.
So, Prem, is there any role for antispasmodics in somebody with an overactive bladder, or just this bladder training is enough?
No, what we're trying to do is do it in stages. So we do the conservative therapies that the panel has suggested, but somewhere along the line we probably need to add selective antimuscarinic drugs, because what we don't want Jason to get to the point where he feels he's not making progress. He'll need to feel something's happening. He's taken that big step to come and see someone, and I think we need to try and move.
What do you recommend?
Look, there are quite a few. Ditropan was the old one that was around for a while, then Detrusitol came along. Now we've got Vesicare, Enablex, Oxytrol, which is the Ditropan patch.
So they're all as good as each other?
No, it's going to be hard to dissect through which would be a favourite. One of them appears to be a little bit better than the others, but for commercial reasons I probably shouldn't say that. But the new antimuscarinic therapies are better. They're less side effects and they're better tolerated. The dry mouth, the constipation's not as big a problem as it used to be.
And desmopressin, if he's drinking a lot, desmopressin might not be that safe.
No. The bladder chart will tell us that. So from that we'll know how much he's drinking, and we'll get a good idea of how much we can control with that.
So in summary, do the basic tests, make sure there's nothing metabolic going on, make sure there's no upper renal damage, there's no obstruction. Fairly simple stuff. We're not even anywhere near urodynamics here. We're just doing the simple stuff. Push fluids, bladder training, pelvic floor exercises, and presumably, and if you're look as if you're going to lose the battle, an antispasmodic for a while.
Yeah.
Trina, are you comfortable with that?
I think that's a pretty good
Did we check that he's constipated or not?
Yeah.
Yeah.
And then I didn't hear mention, just checking that he's constipated.
Right, and sort that out too.
Yeah.
And the fiancé will no doubt have him back pretty sharpish if he's not right. Let's go on to another one. Jack, who's 55, he's an Aboriginal man, he's married, he's a part-time ranger. He smokes about 20 cigarettes a day and is a moderate drinker. His urinary pattern has changed in the last year. He goes to the bathroom a lot, both during the day and at night. And when he has the urge to go, he finds he sometimes leaks before he gets to the toilet. Even the sound of water makes him want to go to the bathroom. His wife and sons have convinced him to see the GP because it's having a big impact on the quality of life, not just of him, but of the family. So, Trina, what do you reckon here with Jack?
Well, I think this is getting a bit more common. We see more like this than we did the previous case. But I think we need to go through the same very systematic history, examination, investigations with this guy. Obviously, we're thinking along different lines. We're thinking benign prostatic hypertrophy, presumably, but we need to exclude other things and check him out. I think definitely what we need to explain is this guy's probably frightened he's got prostate cancer. Most guys with these sort of symptoms are, and I think we can reassure him that he probably hasn't, and if he has, it's not his prostate cancer that's causing these symptoms. Actually. So prostate cancer doesn't present like this. But I think we need to very carefully go through most of the things that we went through before, a good examination, bladder and bowel habits, medications, other things that could be causing urinary problems.
And If you were to do kind of the Rolls-Royce evaluation of him, Virginia, what would you be suggesting here? Apart from this, in terms of his urinary problems.
I probably will be still looking at the Bladder Diary to get a good pictures, what sort of fluids he's drinking, and when does he leak, and when is what is maximum bladder capacity.
And as a man who's out and about in the bush a lot, going to be doing a diary? Yeah.
Well, we normally tell them to do when the days that they're at home, we know it's unrealistic if they're going out to try to do a bladder diary. So as much as they could, if they can even do a couple of days, that will give us some indication how often he leaks and how bad it is.
Steve, just totally non sequitur here, because we're talking about voiding earlier, and I meant to ask the question. Is there any evidence that voiding standing for a man is more effective at emptying the bladder than voiding sitting?
I'm not aware of it. I'm not aware of any evidence.
I'm not aware of it either. Some men preferentially do sit, and they always have. And it's just habit. No, I don't think it makes a difference.
So what would you be doing for Jack?
We've covered a lot of the basics again. The thing, I guess, the prostate cancer issue, I must admit, he's not a screening chap, he's got symptoms. So he's someone who I think should have a PSA and a digital rectal, just to make sure that...
Even though this is not the presenting...
It's not a common presentation, but we don't know that for sure. And I think as long as we do it and we know it's normal, then we can discount it. But I think to not do it in him could lead us some embarrassment when we find out his PSA is 100 and we should have known that, and even though it's not typical. Same reason we would do the ultrasound, just to confirm that he's emptying adequately or not, check his upper tracts. And then where we move on to, I guess, once we've got a clear understanding of his symptoms, how much he's emptying, whether we think he may have obstructive voiding, which is what it's sounding like, then depending on how good the evidence is, if you've got a high post-void residual, you've got a very poor flow.
What is a high post-void residual?
I think most of us would accept over 100 mils would probably be getting high. It would depend how much he voided as well. A rule of thumb is if he voids more than 2/3 of what was there and left less than 1/3, that's probably quite good. So if he left 100 but he voided 500, well, that's pretty good. But if he voided 100 and left 100, that's not so good. But 100 is quite a good figure, but we need to be mindful of how much they voided, how full were they. And
do you often see an obstructive picture with a medium-sized prostate, or is it going to be a whopping?
The size of the prostate is not that relevant. We get caught up in that. That's more a technical issue for us when we're operating. But what we're thinking about is the donut structure and the obstruction being at the inner channel. So you can have a smallish prostate, which is very tight, and you can conversely have quite a large prostate, but a fairly big channel through the middle.
Yes, and in fact, that's the catch, because a TURP is not necessarily going to get you very far if you've got a normal-sized prostate. Unless
what you've shown is clear-cut obstruction, and you may need a urodynamic study in equivocal cases to show whether you've got obstruction. And then if you do have obstruction, you may have a small prostate which just needs what's called a bladder neck incision, just to nick the bladder neck and let it open. But you need to show that you've got obstruction.
Doesn't that make incontinence worse?
No, it doesn't. The bladder neck is sort of the lesser of the TURP type operation. Some people call it a transurethral incision of the prostate. And you get some of these guys where the bladder neck is that camera shutter mechanism, it's very tight. It just doesn't open very easily. And when you cut it, it springs open, but the sphincter beyond the prostate still keeps them continent.
I always thought you got more leakage after a bladder neck incision.
No, you shouldn't. Yeah.
And what's the role, if any, for cystoscopy?
In this chap, if his MSU is normal and his ultrasound view of the bladder is within normal limits, and you're not particularly worried about his bladder, then probably no real indication. However, what we often find with these men is we'll find the microhematuria or something else. We'll find some pyuria or something else. And if we can't explain that away, then we probably do have to look. Irritative symptoms can sometimes be the only sign of carcinoma in situ from the bladder. So let's say, Trina, that it's not terribly impressive. He's not got diabetes. He doesn't seem to, and because of that, he's lucky he's not got renal damage, so we're not talking about incipient renal failure here. So there's not a medical cause for this. The prostate's not terribly, exciting one way or the other. And what would you be doing for him that would really make a difference, do you think?
That makes it a bit more difficult because you don't really know what you're dealing with. But, I mean, certainly there are other rarer things that can cause...
But if it's a mildly obstructive picture, but he's not a candidate for a TURP, at least not yet, what would you be doing for him?
You could possibly try some medications. You could talk to him about
alpha blocker or something?
Possibly. You could possibly try and see if there's an anxiety or an emotional psychological issue that can make a lot of bladder symptoms a lot worse. Certainly we could talk to continence nurses or continence physiotherapists and get them to do some bladder training work on him.
So what would you do, Virginia?
As I mentioned before, we talked about the bladder training before. First, I just make sure he's empty his bladder quite well before we can actually do bladder training. If they are retaining, bladder training is contraindicated. So first...
Sorry, if what?
If they're retaining,
oh, I see.
Yeah,
right.
so we can't tell them to hold on because they're already not emptying well. So if we know they're emptying well, then we can do the bladder training, like the deferral technique and good bladder habit and bowel management.
But if he's retaining, do pelvic floor exercises make any difference here?
I don't know. It may. It's not going to harm. It's not going to hurt. Put it that way.
Right.
But whether it's going to help, I would even be tempted to look at if he was anti-medication, maybe looking at some of those natural saw palmetto type things as well. I don't know whether
some Chinese herb stuff. That
it depends on the degree of the problem.
And presumably, some men, if they're reassured they've not got cancer. And they're not too bothered by the symptoms, they're not happy to live with it now that they're not anxious, they often just move on.
Yes.
Until it becomes a problem.
And it's where the bladder training can sometimes just tip them over from bothersome symptoms to symptoms that they can cope with. The other issue you raised was if you've got an inkling they've got some degree of outlet obstruction, but not enough for the TURP, for example, then a selective alpha blocker like Flomextra would be fine. People still use Prazosin. It's fine, it's a lot cheaper because of the way it's available, but it does cause postural hypotension, so that's often a problem in the elderly.
And you mentioned urodynamic studies for when you're getting down the line.
Yeah.
They're not covered, are they, by and large?
No,
so you've got
not.
to pay for them. So it's
you
an
do,
issue.
yeah. That's a cost issue, but it might just help you decide whether you're going to operate on him or not, because you may find his obstruction's not as marked as you thought, and then you may suggest the continence nurse will be a better option for him. And I do agree with the panel that I think in most cases the bladder training is a good idea. It'll only get them a bit better, and sometimes it'll get them dramatically better.
Sorry, Norman, the urodynamics, actually some centres are covered by Medicare bulk bill. Some of the big centres, you can have access.
So you may be able to refer in from a smaller town to a larger one.
Yeah.
We've actually had a couple of questions. This one comes from a GP in rural Queensland. What advice can I give my patients who have incontinence but who are also saying it's affecting their sexual relationship with their wife?
I'd like to know firstly just what sort of, I need to know the nature of the problem, and is it leakage when they're actually having sex, or is it beforehand or after? Just exactly the detail is really what I'd need to know first, and then work out a plan of how they could actually address it. It's not happening only in sex, it's there for a reason, I would think.
So what are the common complaints that men come up with incontinence? In this case, from the history given attached to this question, it's more that it's erectile dysfunction, and he's just embarrassed and fearful that he's going to leak during intercourse.
Well, I wonder if he's been doing his pelvic floor exercises as a starting point. I wonder what his fluid intake's like. I bet he's not drinking as much as he should be. Any other ideas?
I'd suggest that we don't really know what the real reason is, but there's a really good chance that if he's incontinent, this could be post-radical prostatectomy. He's certainly going to be impotent to a certain degree. And if he's trying to have sex when he's incontinent and impotent at the same time, it can be a major problem to him, but there is a way of doing it. And he's really got to talk to professionals, talk to counsellors, talk to physios, talk to anyone he wants to, but it is possible to have good sex with both those problems.
And a second question here is, what role do medications play in the causation of incontinence in men? Prem?
Medications in groups, if you start with diuretics, sometimes just putting more fluid into that bladder sets it off. So you've got this overactive bladder where they're coping, but then you get the diuretic and off you go. Sometimes people get inadvertently put onto alpha blockers, and then they start becoming incontinent. You see that in women sometimes, so still on Prazosin, for example, for blood pressure control. So every once in a while you hit the jackpot, you see someone coming down Prazosin and you think, wow, you stop that and it's done. So I think also history will guide you sometimes when they've gone on to something, and they say, when you say when did it happen, you might well find out.
Also, another classic cause is the people that have mental illness and some of the antipsychotics and things like that knock them out so much that they wet the bed every night virtually because of the antipsychotic or medication they're on, and sometimes a review of that medication may help too.
Another question here from a doctor in South Australia. My patients find it counterintuitive to drink more fluids than less to aid their incontinence. What's the most effective way to explain this to get the message across? Trina?
Well, I think basically by explaining that restricting your fluids is not going to have an impact on your continence, but drinking more fluid and getting less concentrated, less irritant urine is going to have a beneficial effect on continence issues. And just explaining the reversal, that restricting fluids often can make problems worse.
Up there. Let's go on to our next case study. Jim's 85 years old, living with his daughter. His daughter takes him to see you, Trina. He's complaining that he's wetting himself. Well, the daughter's complaining he's wetting himself. He's often confused, his memory's bad, and the daughter thinks he actually doesn't realise he's doing it, and he's actually not going to the bathroom very much, seems to be constipated. Bread and butter.
Bread and butter. This is a much more common presentation. Where to start? I think often... this is
often the trigger for institutional care, isn't it?
I was just going to say that often the trigger for carers bringing their relatives or the one they care for in to see us, or for requesting placement, is continence issues. It's often the straw that breaks the camel's back. People find it hard to deal with, and some people just can't deal with it. They just physically, emotionally cannot bring themselves to deal with this sort of problem, especially if it's a parent or a loved one. Where to start? I mean, this is our bread and butter, really. You have to really drill down and work out with this guy, you know, what is causing his continence problems, what's fixable, what can we improve on, and if we can't fix or improve it, how best can we manage it? And we need to go through the whole list of things.
So what medications he's on?
Medications, constipation, renal function, diabetes, falls, mental state, if it's an acute change, acute confusional state, if it's a neurological or frontal lobe thing, if it's just seems to be a progressive dementing type illness that continence problems can then become part of. And I think often
always a mixed picture, a little bit of this and a little bit of that.
I think in old people who are, you know, this guy is probably on several medications, it's going to definitely be a mixed picture. Some of them we can probably do something about. If we're lucky, we might even find continence problems we can fix, but most of the time we can improve and support and manage them as best we can.
I mean, you're not going to get him to do pelvic floor exercises.
No, you're not going to get this guy to do a bladder diary.
Yeah.
No, so you really have to look at what you can do to help the carer and the patient, rather than expecting the patient to do things that he's just not capable of doing.
So what's the modern bag of tricks to help her stay at home?
Well, we've got a few here to show people. Most people will probably know these pull-up pants for large amount of incontinence. For a dementia patient, probably will be quite good because they think that they're wearing a pair of underpants, so they wouldn't know any difference. Other things in the market.
And these are highly absorbent, and they tend to deal with odour as well, don't they? Yeah,
this is quite keep the odour, as well as it's quite dry. You can't feel anything. They usually have a capacity. You see any continence advisor, and they will be able to recommend a suitable product, and also get one from one of the company for patient to try before we actually order them on some sort of funding scheme, because the continence product is very expensive. There's a couple other things that...
how would you know what volume, in other words, what... is that just, you know, try it and see sort of thing?
The company actually will show you, let's say this product, they will actually tell you what is the maximum capacity. We normally go down, you know, 10% less than what they recommend. Even, let's say if they recommend this whole 500. So if anybody leakage around 400, we'll use that. If anybody leak 500, we actually will be using something a bit more absorbent.
So it'll give you a bit of extra capacity.
Yeah, that's right.
And one of the things I suggest on the line is that if you're not sure how much a person's losing, get an empty pad, weigh it on the kitchen scales, and when the person's used it and you're going to get rid of it, put it in a plastic bag and weigh it again. That's going to tell you how much the person's losing, and therefore you know then what sort of product you need, because you can measure the capacity of how much each product is.
That's like a PET test.
Mm.
Yeah,
Yeah.
informal PET test. Other products in on the market are this washable one. People, you know, if they're traveling and they don't want to be embarrassed wearing anything disposable nappy, they can wear something washable like this. They got a capacity. This is look like the children's trainer pants, holds about 200-300. So if you...
So that's really for minor leakage.
Yeah, for minor leakage, but this looks quite good. That they would not feel embarrassed wearing this, because this is just like wearing a pair of underpants. For smaller leakage, these are commonly available in the supermarket that they can get. This holds a little bit more. At nighttime, if there's an issue, if provided this dementia man will let it stay on. This is the condom drainage bag. One of the problem in elderly men, dementia men.
They pull it off.
They pull it off. They don't like it. It's irritating them. And other things new is a urinal. Given the man is demented, so he might not be suitable for him. But this is quite a good urine bag. You fill the urine and you tip it, non-spillable. So it holds a liter. So because of this man's demented, he might not be suitable. But other people...
Great for travelling.
Yeah, good for travelling, going, you know, camping. You just roll it up and just put it in your shirt or something.
Good.
And filled.
And filled.
Yes.
And use it as a hot water bottle, double as hot water bottle.
Filled.
We're getting all the toilet humour out now, or later?
It'll come.
Peter, tell us your story.
I guess I can smile about it now, but when I was 52, I got a nice birthday present. I actually am a sports medicine physio, and that was my life, and it still is. But I was diagnosed with prostate cancer. At the time, I was pretty much a sort of typical male. There wasn't any awareness of what prostate cancer was or what a prostate was. Even as a health professional, I had no idea. So I went into the whole experience not knowing a lot about it, and I chose surgery, which was the valid thing to do because my father died early of cancer as well, so I wanted it out. But unfortunately, the experience left me severely incontinent. After about 3 months, I was still going through about 6 pads a day. That led to depression, which I never had before because I couldn't get rid of it. It affected my life socially. I couldn't go out, certainly sexually. I couldn't work. It really made...
Had you been prepared for this?
Well, I hadn't been prepared at all, and I guess that's one of the legacies I really will talk about. No, I was told I might become incontinent, but the fact is that when a man is told that you've got cancer and you're going to die, and you might die...
That's all you can hear.
The words incontinence and impotence don't mean a thing, and even if they do say a few words like, it might be a problem for a few months, or there's a good chance you'll get out of it, it still doesn't mean anything. You want to save your life. So you automatically do that. But once the reality hits you, that you're left with this devastation to your life, it gives you depression, which I've never had before. Anyway, what happened at the 3 months mark, and of course I was impotent at the same time. I just couldn't do anything. And even if I was, I couldn't do anything anyway because of the incontinence. And it wasn't my prime focus at the time. I did realise that other female physios treated females with incontinence. So I sought up a few female friends of mine, and they taught me those basic pelvic floor exercises I just taught you before, which I hope you'll do later on.
Still doing them now.
Indeed, and they dropped it down over the next few months down to about less than a pad a day. It was quite manageable, so I got on with life. But after a time, the doctors and the surgeons around the place who knew I'd got this sort of a result started sending patients to me, so I started to treat male patients and started to get a good result with them. But it still wasn't good enough for me. After a few months, I was awarded a fellowship to go to the States to study, to look at some of what they're doing over there to try and manage it. A lot of the good research was being done here in Australia, which I didn't know at the time, but what I really found out was I developed a program on on 4 levels, which really helped to dry it up. The first level was, of course, basic pelvic floor exercises, but the second one was, at the time, there was some really good research showing the connection between the pelvic floor, the abdominal muscles, and the diaphragm, how they work as a dynamic cylinder. And the idea, of course, is when they contract, they shunt the weight down your legs to protect your back, as a normal physio will tell you. But when they do work, if you've got a weak pelvic floor or a weak bladder, you will squirt. the point is they work as a team. So then I worked out, and the research showed that if you contract your abdominal muscles and integrate them with your pelvic floors, you will make the pelvic floor muscles stronger. So I needed to make them stronger. So I started myself on a very rigid program of pelvic floor muscles and abdominal muscle contractions together. And the third level, back on that little slide, was to dynamically and functionally retrain the components of the reflex system, which I'll talk about in a minute. I'll go back to the abdominals now and tell you how I integrated that, because I think that's an important one.
Well, just before then, and then there's general fitness.
And then there's general fitness, which is number 4, yes indeed. And that relates to getting blood up there, but really to give the man something to sort of fight for. Well, I'll mention that just now because men need to feel in control of things. They just can't. I feel about probably 60% of men will get better, will make some improvement just by pelvic floor muscles alone, but that's not enough. It's a really piddly thing to do, just sit there and go up and down. It's really annoying. And you don't feel you're getting far. But to give them an exercise program that's really hard and heavy, and they can get goals, they'll take it at heart. They'll start exercising, they'll start running, and they'll start to do fitness work, and they'll do basic back to gym work, swimming, whatever, and they'll start to feel better in themselves. Their endorphins will raise. They'll start to raise their depression. But I'll go back to the abdominals so I can show you how I integrated that if I can. Can I go to the exercises? What I started off by doing...
You look that good in a swimsuit, Peter.
Yeah, I've done a lot of training. What I found out was that the rotator muscle group is the important one. They actually attached to the pelvic floor muscles. So I taught my model how to contract her lower pelvic floor, her rotator muscles, and pretend I'm going to whack her in the stomach so she draws the navel into the floor to get them working. And then I get her to contract the pelvic floor muscles at the same time so they're connecting, and then get her to do a half sit-up or a crunch, which is, as long as she's got a hand behind her to protect the neck, that'll be fine. And then she'll lie down again. And then that will just start the rectus femoris and the rotators working. But to make them work even more deliberately, I get her to take her right elbow across to her left knee, which is the next slide.
So you do a cross.
Yeah, and then you take it back and you take the left one across to the right knee. So you're going to get the rotator muscles.
At the same time as contracting your pelvic muscles.
That's absolutely important because they've got to get.
And how many reps do you do of that?
Well, I'd start off by just doing about 6 up and about 6 each way, just to get the connection, just to make sure they know they have to work as a team. And then I'll build up to 8 and 8 and 8, and then 10 and 10 and 10, and that would be the minimum. 30 reps would be what you need to do to get some basic. You once a day is enough. And of course, there's a couple of other side issues, there's a couple of other nice side effects of this. It will also flatten your stomach out, and it will protect your back. It's the exercise that physios have done for years.
So you look like Brad Pitt.
You will get the 3 all for the same. You get 3 for the same price, and you'll be dry. But it gives men something to work at. And then if they want to get even better, they'll do 2 sets of that, and then even 90 if they want to. They don't need to, but if they want to do, they'll put a weight behind their head, and that will really make the pelvic floors work hard. Try it sometime.
And you went to the extreme.
Well, I went to the extreme. I really wanted to prove, and I'll mention that in a minute. That was one of the legacies, because the third level relates to the reflexes, to try and get these muscles working faster and faster, and try and preempt movement. What happens is if I'm going to shake your hand 0.0032 of a second before my hand actually moves forward, every other major muscle in the body contracts in a hurry to stop me from falling forward. It's called a forward feed reflex. But in that time, the muscles suddenly contract, and I will squirt. And we'll just go to pick up a briefcase, shake hands, pick up something on the floor, cough, sneeze. So the patient's got to be trained to beat that.
So you don't have to think about it.
Yeah, so it happens automatically. So if they know they're going to leak picking up a briefcase, I'll get them to pull the pelvic floors on before they do it, or to hit a golf ball, or to run around the corner, or to get out of a chair. So the way to do that is to get them to start walking, to start jogging, to pull the pelvic floor muscles on, and to get up hills, and to get on uneven grounds.
And you went up the ultimate hill just very briefly, Kilimanjaro.
I did. That was one of the legacies. I wanted to prove something to myself. After about 4 years of working this, I got myself pretty dry. And at 60 years old, 7 years after the diagnosis, I wanted to prove my program worked. I wanted to prove I was still alive.
And did you get back dry?
Well, indeed I did. I started off because I had to put heavy weights on at the beginning. I got a few squirts, which worried me. But after about 5 days, I got to this point here, which is 15,000 feet, and the snows came in. It was very cold, minus 20 degrees. The worry was if my program failed, I was going to lose everything with the cold. As it turned out, you get up at 10:30 in the morning and you go up to meet the sunrise.
Could be that your plumbing was frozen.
Well, that was my worry, that it was. It could have been frozen, but it wasn't.
And did you get all that in Medicare? That was very impressive.
I should have tried for it. I don't think that had passed that.
Peter, thanks. Let's look at how some people are putting this into practice. Ermina's, and it might apply to some country towns. Ermina is a continence physiotherapist with the ACT Men's Continence Clinic, and here she talks about the work that she does.
With incontinence management, the physiotherapist specialises on the pelvic floor muscles and how they relate to the organs above them, that is the bladder and the bowel, to try and improve people's ability to control the bladder and the bowel. Okay, now you were doing your pelvic floor exercises prior to surgery?
Yep, about 2 weeks before.
The biggest group that I see are men who have undergone or are about to undergo prostate surgery. I get a lot of referrals from urologists. Sending their patients before surgery actually improves their after surgery outcomes.
Do what the doc says, etc., etc.
For a lot of men, the initial incontinence is quite a shock, but if they know to expect it, it's a lot better.
I just sort of got in the routine.
When I can give them the information beforehand, then they can be prepared for what to expect after surgery.
So,
yep. How have you gained with your pelvic floor exercise? I find that I need to be very empathetic to try and encourage them to voice their concerns. I try to normalise it. Now, men feel very isolated after surgery, but when they find out that of the men who have prostate surgery, radical prostatectomies, probably 80% are incontinent in the first month. Now that scares them, but when I tell them that by 12 months, only 5 to 10% still have a significant problem, they're much happier. Okay, so the pelvic floor muscles that we're talking about hang between the pubic bone, that's the bone here at the front of your stomach, right round to the tailbone. So it hangs like a hammock. One of the strategies that we use is pelvic floor exercises. They're much easier to learn when all the anatomy is still intact. So men who've not had surgery yet can do pelvic floor exercises so that once they've had surgery, all they need to do is recall how they did it before their surgery in order to do it properly after surgery. Trying to learn to do pelvic floor exercises after you've had surgery is much harder because there's swelling in the pelvic area, the nerves might be damaged from the surgery, and there might be pain down there too. But I don't know, are you feeling anything in there yet? I've been the ruination of quite a few men's handicap because I make them tighten up while they swing the golf club. Tightening the muscles willy-nilly when you're sitting in the car at a red light, that's actually not going to strengthen the pelvic floor if you leak when you're playing golf. So it's really important that men are taught to do their exercises in a way that's functional to their level of activity. Now, there are programs around where men are told, okay, you've got to do crunches and sit-ups, and while you do them, pull up your pelvic floor. If you do crunches and sit-ups normally, and that's when you leak, then brilliant. That's when you should be doing pelvic floor exercises. However, for most men, they leak when they are walking the dog or when they're playing bowls. So I teach pelvic floor muscle training in that context. A lot of men are worried about erectile dysfunction. Now, erectile dysfunction is something that is, again, an unfortunate side effect of having prostate surgery. Reassuring them is very, very important, letting them know that this is normal part of the recovery. And I find that for most guys, just having someone to talk to is really, really comforting. I think it's very important that GPs specifically ask their patients, their male patients, about erectile functioning, because the men will not come out and say to them, I can't get it up. Yeah, it's not just men with prostate cancer that come and see me. I will also see younger men, in fact men of any age, who have problems with bladder control, that have what we call overactive bladder. It's very important that we teach men and women how to deal with that. Okay, well, we're going to have a look, see if I can find your bladder. I also think it's important that men are given strategies to stay in control. Mind over bladder is what I call it. And that's something that will help them control their bladder throughout their day. Now that's your bladder there. Can I get you to tighten your pelvic floor? Recently we've started experimenting with real-time ultrasound. We can see how the pelvic floor moves, watching the base of the bladder move up and down. Now this is quite exciting because we can actually do pelvic floor assessments without the embarrassing having a finger up the backside. Excellent, you can do it.
I think it's very important that, especially GPs, when the men finally do come in for their annual checkup, actually specifically ask their patients, do they have any problems with the waterworks? Has the stream changed in the last however long? Are they having problems initiating? Are they having problems actually passing urine? GPs, physiotherapists, nurses need to remember that men also have a bladder and a pelvic floor and that they might have problems.
Amina Nahan, she didn't like your abdominal crunches much there, Peter.
No, it's not that she didn't like them. She didn't like them for just normal men. For any man who wants to be active, I hope that she was reinforcing that. And anyway, I believe that for every man they should be doing abdominal crunches, no matter who they are. It's part of a lifestyle, as far as I'm concerned.
And one of the big messages there is the pre-operative training.
And I have to agree thoroughly. I would reinforce that. I would love every man, before they have surgery, I love the urologist to send them to a health professional to learn to do the pelvic floor exercises, to understand about impotence and the effect it will have in their life, the psychosocial effects, to see professionals about all those things. They've got a nasty enemy here. The more of a general they are themselves to understand what they're going through, the better they'll cope.
And Prem, have you noticed it making a difference, the fact that if they have this pre-training?
Yeah, there's no doubt it makes a difference. I think our techniques are improving with time, but now with the continence nurses working with us very closely more and more, I think if men know what they have to do before they have to do it, they're much better at doing it afterwards.
What about when they've had radiation treatment, Virginia?
Radiation treatment, the men still got a lot of inflammation with the radiation cystitis.
It can be pretty fearsome with brachytherapy, can't it? That's more urethritis, isn't it?
Radiation cystitis and radiation proctitis, they usually get a lot of diarrhea and frequency and urgency. I want to pick up, sorry, I go back a little bit. I want to pick up on the point that Peter was saying about before surgery, the men should be taught how to do the pelvic floor exercise. I think it's important to learn it before they have surgery because they don't have the swelling and they don't have the catheter, and also important for them to be able to do something to empower the man to contribute to the recovery. So it's important for them to do. And also I think is we also got to show them like the catheter care, because some of the men have never seen a catheter before. So it is important to also mention about catheter care.
Because they'll have them in for a few days.
Yes, that's right.
And Trina, presumably if you get them into this bladder training before surgery, it helps to reduce the stigma afterwards.
Well, hopefully it does, and I think just by talking about it and by telling people that yes,
it normalises
it all, and you're not the only one that will have these problems. Yes, we know it will happen, but we also know how we can minimise the impact.
Any role for the pharmacist in this, community pharmacist?
Huge role, not necessarily in prostate cancer and problems or prostate surgery, but we find one of our biggest allies for information gathering, especially in older people and a lot of medication, is their community pharmacist, who they'll often have a very good relationship with. They'll often be buying their pads and continence aids from the pharmacist, and they may not even tell the GP because they think that because they're old it's the normal thing. And often we find that when we do HMRs, home medications reviews, on these people, that it's one of the things that the pharmacist will pick up on as being one of the most important things in that patient's life. Often the pharmacist will say, if I could do something, if I could change something, what would it be? And that's the one thing that the patients often say.
Steve?
I'd actually back that up too, because a lot of pharmacists bring us up on the helpline talking about exactly that thing. Yep. And that gives me opportunity to talk about the funding schemes and availability of other products, where it can be located. It just opens up a whole enormous amount of things.
So tell us about the funding schemes.
Well, there's a number of funding schemes in Australia. The national one is the Continence AIDS Assistance Scheme, $470 per financial year. And then there's other schemes like the DVA RAP scheme. There are state schemes in virtually every state except ACT that all help. They all have different qualifications and things, but they all provide a range of products for people, and we're getting back to that comment about if we can't fix it, or at least we can manage it better, and using products correctly is certainly one way of managing things better and keeps the person at home a lot longer.
And is there a one-stop shop for accessing these, or you just got to go to each one specific to your jurisdiction?
Well, a lot of people call this the helpline because it isn't simple to know exactly where to go. So we have to know where all the different schemes are and where to get access to the various people. And some schemes through GPs. And
there before you is the number, 1800 33 0066 for your one-stop shop.
We try to be.
You might even get your smiling voice on the line, Steve.
Very possible.
And if you're not dry by 12 months, I mean, what sort of technology have you got up your sleeves these days as a urologist?
The technology is increasing. We now have 3 types of male slings that we can do. The artificial urinary sphincter has been around for a while, and I think it's always sad.
So you're starting to do the similar operations to women?
Very much so, borrowing from the technology that the meshes that we're using in women, the transvaginal slings and transobturator slings. I think it's very sad if you see someone 5 years out and they come to you and they say, I'm still wearing 5 pads a day, and that's unacceptable. I think that by 12 months, if they're not continuing to improve, some decision needs to be made about, are we going to fix this in a period of time?
Does early intervention make a difference here, Trina?
I think early intervention nearly always makes a difference. The earlier we can get to things, the more we can normalise it, the more support there is for people, and certainly I think the earlier we get to things, the better chance we have of improving things, but I don't think it's ever too late either.
And is there any evidence for primary prevention, Steve, stopping it all in the first place?
Not so much primary prevention. I have a favourite line that says, if you do nothing, gravity will take over. And
cosmetically and
everywhere else.
Urologically.
Exactly. So it's just good bladder habits, good bowel habits, and
walk a lot on your hands.
Well, at least seek help early rather than late.
So what are your takeaway messages for people to take away from this programme? Virginia?
I would like to start with a little story. One day I was called to a ward for assessment. When I entered the ward, the nurse asked me, "Are you incontinent?" I said, "I beg your pardon." She repeated the question again. So I looked at the front and I looked at my back. Then I realized what she meant. What she meant was, am I the incontinence nurse? So my take-home message is, on behalf of all the continents in Australia, please and please, we are the continence nurses. We want to make people continent. We're treating people across the lifespan, from cradle to the frame, the walking frame.
We've got the message, Virginia.
Thank you.
You're the walking dryness. Steve?
My take-home message is always just ring the helpline if you have any queries about bladder or bowel management, any sort of problems. We'll point you in the right direction. We'll provide you with written information and ideas on how to manage things.
Peter?
One of the other legacies of my experience was that I helped to set up the Prostate Cancer Foundation. We now have about 20 groups in Queensland. I was the first one to set one up. We have 80 throughout Australia. We have support there for any man who is diagnosed and his partner, and I recommend the partners are just as valuable. Don't be slow to get support from any of these groups throughout Australia. And if you are left with any sort of incontinence, fitness, global fitness is the way to go. This is often an opportunity for a man to start to change his whole lifestyle around, not just to go walking, but to be really an athlete again, to get back into some sort of life. And they'll often do that. They'll change their whole lifestyle around. So this is my chance to become who I was.
Might even be an athlete for the first time in their lives.
They may well be, and I hope that happens if I can change them that much.
Trina?
I think problems with continence are very common, and I think the worst thing we can do is not ask about them and not find out about them. I think they impact enormously on patients' quality of life, and I think it's important that we all find out what is available in our area nationally, what help is out there, what other health professionals there are, and work as a team to do the best we can.
And reduce stigma by normalising it.
Absolutely.
Prem?
Well, I think urologists can help, and I think if we get to the point...
That's a comfort. Otherwise you might find another career for yourself.
We sometimes get let out. But once we've done all those conservative things, once a period of time has passed, then we may need to look at reconstructive surgery, and that's not admitting failure, that's just fixing the problem that's not fixing itself.
Thank you all very much indeed. I hope you've enjoyed tonight's programme as well. If you're interested in obtaining more information about the issues raised, there are a number of resources available on the Rural Health Education Foundation's website, and that's at rhef.com.au. Don't forget to complete and send in your evaluation forms, and please register for CPD points by completing the attendance sheet. And don't forget, on the website, by the way, there are also MP3 files. You can download a podcast of all our programmes. Our thanks to the Department of Health and Ageing for making this programme possible, but thanks to you for taking the time to attend and contribute. I'm Norman Swan. From all of us, bye for now.